speak with you all today. So these are my disclosures. So in the next 15 minutes, what I want to do is describe cancer patterns around Caribbean Black patients in South Florida. I want to illustrate the importance of kind of an individualized evaluation of risk among patients within this community, and to really understand that we need to look at this community as actually a very diverse community. And then perhaps suggest some strategies for improved outcomes and understanding of risk in these patients. So I want to start, however, with a little bit of a history lesson, because I think this is really important in terms of perspective about how we should be looking at this community in Florida. So this is actually a pictorial of the transatlantic slave trade. So as we know, tens of millions of men and women were transported from West Africa to the Americas over the course of several hundred years. And you can see here that the vast majority are from right at that area where it is currently Nigeria. And men and women were transported to South America, the Caribbean, and the United States, or North America. But we also know that they didn't stay there, that there was substantial intermixing and moving. And so what we had here is a very unique opportunity for admixture with both the native and the European populations in the context of geographically isolated islands. And so what we're looking at is the development of very unique sociocultural perspectives, sociocultural practices, as well as very interesting admixture that may augment specific changes in the genome that either increase or decrease cancer risk. And so for us, why it is important to understand cancer in these patients specifically. And that's again because the Black population in the United States is not uniform. It is polylythic. We know 35% of the US Black population is made up of Caribbean nationals. 50% of the non-Hispanic Black immigrant population to the US is Caribbean. We know that the largest population of Black immigrants in the US is the Caribbean and West African representatives. And we also know that the population of Black immigrants in the US has risen by more than 70% in the last 20 years. Here in Florida, the largest share of newly arrived Caribbean immigrants is from Haiti and Jamaica, and we accept the largest amount of immigrants from the Caribbean. And so it's really important for us from a public health standpoint to understand the patients that we are treating. So we did a study on patients with endometrial cancer, and one of the secondary analyses that we did was looking at the genomic ancestry. So this is about 62 patients. And what you can see here is from a genomic, like a DNA perspective, we have very admixed and unique populations. So you can see here that we've got women who are represented by African ancestry, European ancestry, and Native American ancestry, but there is significant intermixing of the genome here. And so again, just reinforcing that even from a genomic standpoint, our patients are not uniform. This was actually done using Cancer Genome Atlas data by the NCI, and these are all women who self-identified as Black, all with endometrial cancer. And you can see that even though within the same racial construct they identify as Black, their genomic ancestry is substantially variable. So again, there's an added layer of complexity and understanding that we need to have from a genetic perspective, even aside from things like socioeconomics. So I'm going to take some time to go over several cancers that have very unique outcomes and presentations here with our community in South Florida. Because I don't want Carmen standing right here next to me at the 15-minute mark, I'm not going to be able to hit on every single one. But what I hope to do in the next few minutes is really kind of demonstrate to you how unique these populations are. So this is one of the first papers that we did in endometrial cancer. Endometrium is the lining on the inside of the uterus. And what we did was look at women who self-identified as Black and then evaluate them based on where they were born, either in the Caribbean or in the United States. And what we found here is that there was a difference in stage presentation, which speaks to either an access issue or a tumor biology issue. But one thing that was particularly interesting for us is the proportion of women who had really aggressive types of cancer. So we saw that 72% of Caribbean-born Black women and 64% of US-born Black women had really aggressive endometrial cancers. In contrast, in SEER database, 29% of the US population of Black women present with aggressive endometrial cancer. So what we are seeing kind of geographically is a substantial difference in the types of tumors that are presenting to us. These are actually data that I worked on with Dr. Pinheiro. And what we did was look at Florida and New York data, again, looking at whites, Hispanics, and then Blacks born in the US versus Blacks born in the Caribbean. And what you can see here is that across all of these histologic types, all of which are these high-grade different endometrial tumors, you can see that there is a marked increase in risk for those born in the US versus those born in the Caribbean. And so why is that? Is there something in the tumor genome that is predisposing to a more aggressive type of cancer that we have yet to identify? We also can see that in the second portion of this slide that there has been an increase in the risk kind of across the board of these types of tumors over the last decade. We looked very recently at country of birth and outcomes for endometrial cancer, and what you can see here is that relative to US-born Black women, Jamaican women have an overall survival advantage, but Haitian-born Black women have a worse overall survival advantage. Now, when we get into these things, like Dr. Pinheiro had mentioned, there's a number of factors that may go into this, but it really calls to mind, are we looking at a tumor biology treatment response kind of thing, or are we looking at other kind of more intangible variables like family structure, access to care, socioeconomic status, transportation, things like that? We worked on some data with breast cancer, and these are again looking at US versus Caribbean-born Black women. This was done with one of our HEMOC fellows. And what we can see here is that Caribbean-born Black women seem to have a better overall survival than US-born Black women. So this is something that we actually have seen in endometrial cancer, and that is now being reproduced in our breast cancer patients. And what's interesting is when you really kind of subdivide where these women are born, there is marked variation by the specific country. And so this is a little bit of a busy slide, but what you can see here at the bottom curves is that Haitian patients and Cubans and US-born Black women tend to do worse than some of the others. And so this even inter-island variation really kind of speaks to differences in the underlying tumor. It's important for us to know this as we're developing our treatment plans for the patients. Considering cervical cancer, which we know is a big burden, especially among women of lower socioeconomic status, we wanted to see if within the state of Florida there was a difference between Black and white US-born versus Caribbean-born patients. And what you can see here is that Black women born in the United States have much, much worse survival than all other groups, even Caribbean-born Black women. And so, again, we're left with this thing that we're seeing Caribbean patients do better from a survival perspective than Black women born in the United States. We see this even for ovarian cancer. These are some data that were generated using Florida Cancer Data Service a couple of years ago. And what you can see is that when we're looking at the hazard ratios or an estimation of the risk for death, it's higher amongst non-Hispanic Blacks than it is for Hispanic patients relative to white patients overall. And what's important to note here is that these analyses were adjusted for a number of factors, and we still kind of see consistency in these data. These are some data from within Sylvester that we looked at for ovarian cancer. Again, looking at white, Black, non-Hispanic, or white and Black Hispanic, all born in the Caribbean. And what we can see here is that there is an attenuation of the risk of death when somebody has background of Hispanic ethnicity or identifies as having Hispanic ethnicity. And so this goes back to a little bit of what Dr. Pinheiro was talking about in the last talk about the Hispanic paradox and really kind of understanding what are the things that are going into this. In head and neck cancer, we see substantial variation by country of birth. So even if you just look all the way at the left-hand side of the left column, you can see variation in risk by Barbados, Guadeloupe, and Trinidad. You can see variation in risk by African country of birth. And you can also see Florida versus SEER data, which is representative of the rest of the country. And so again, further underscoring that there is a difference by multiple disease types between those born in the Caribbean and those not. And even within the Caribbean, there's substantial variability. And then one final paper also by Dr. Pinheiro. This is looking at men's cancers across multiple different types: bladder, lung, pancreas, liver, colorectal, myeloma, prostate, and stomach. And you can see that Afro-Caribbean men do have much lower risk than African-American men. Again, speaking to some sort of underlying biology. And so what is driving all of this? We know that there are variations in sociocultural norms by all of these subpopulations of people. Are we seeing delays of care? And that's why people are getting in late, and that's why we're seeing a stage shift. But are we also underappreciating practices that may affect the local tissue environment? So that's things like pelvic hygiene practices, exercise practices, all of which kind of alter the environment in which the tumor is developing. We know very specifically that for Haitian women, the way that they do their pelvic hygiene actually accelerates the acquisition of the human papillomavirus, which increases cervical cancer risk. So how do we appreciate those kinds of things? Are we seeing differences in outcomes because of tumor factors alone? So is it something in the biology that we could potentially tie back to their ancestry that we could identify for early detection and risk assessment? Is there a role of geography or environmental exposure? Where are people getting their food? How are they preparing their food? What types of foods are they eating? Because we know there's substantial variability throughout the Caribbean. And similarly, where do people get their water, and are there contaminants within the water? Again, we talk about the immigration effect. So this is even a little bit different than the Hispanic paradox, but with the healthy immigrant effect, the theory is that those who come to the United States are physically healthier than those who had to stay back home. And so are we seeing better outcomes because the people here aren't truly representative of everybody from the country from which they were born? And then markers of stress. We talked earlier about psychosocial stress. We know there's physiologic stress as a result of things like immigration, financial insecurity, architectural insecurity, things like that. And then again, is tumor risk embedded in the genome or related to ancestry? And then how does admixture, meaning what percent African ancestry versus Native American ancestry versus European ancestry is attributable to the risk, and how can we see worsening or attenuation as a result? And so it's really important to appreciate this because we have a lot of opportunities to impact risk and outcomes. So in terms of access, we see these variations in survival. How do we improve clinical trial participation in this subgroup specifically, which we know is classic